Hi, thanks for coming to this talk about social networks and avoidable emergency department attendances. I'm Catherine Pope from the University of Oxford, and I'd like to acknowledge my co-authors Gemma McKenna, Sandy Walker and Anne Rogers. There's been a 16% rise in emergency admissions over the past 5 years and an average of 3,000 more emergency department attendances every day. 11% of patients are discharged from the emergency department without treatment, and 44% require no follow-up. It seems that there is a vast pool of potentially avoidable, so-called inappropriate ED attendances. During the COVID-19 pandemic, the advice to stay home and protect the NHS saw a dramatic drop in hospital attendances for people without COVID symptoms. So much so that my colleagues became concerned about the missing sick. The characterisation of attendance as inappropriate creates very powerful binaries. You are bad if you pitch up at the ED. You are good if you stay at home. Inappropriate attenders are anomalous individuals. If they are out of place, the solution is redirection. Posters like these individualise responsibility, placing it firmly on the shoulders of the patient. As a reader, you need to understand and act appropriately. Confronted by this neoliberal individualisation, social scientists often back up and direct their attention to wider social structures and social networks. We know that family and lay referral networks influence help seeking. Social networks provide support and are a source of normative regulation. Vasilev and colleagues point out that social networks provide 3 mechanisms for mobilising support. Navigation, who should I ask, where is help to be found? Negotiation, asking a family member, do you think I should go to the ED now? And collective efficacy, do my neighbours go to the ED when they're sick? We conducted a small interview study as part of a larger programme of work in the NIHR Clark, Wessex. This took place in a single emergency department, and we used convenience sampling, conducting interviews at different times of the day and night on different days of the week in an attempt to ensure diversity of our sample. Our sample ended up being mainly white, but it reflected some of the migrant community in the locality, notably East Europeans. Interviewees were identified by a nurse practitioner at triage, and they had injuries or conditions that did not require immediate treatment, and the patient was therefore capable of waiting to be seen. And at this point, they were introduced to the researcher who invited them to participate and obtained consent. In the interviews, we asked them why they'd visited the ED and about the information and people who'd helped them decide to attend. Then we asked them to map their social networks, thinking aloud as they did. First, we asked them about their actual networks, the ones that had been implicated in this attendance, and then about their imaginary networks, the help that they might have or could have called upon. We subsequently analysed the data using standard thematic approaches, and we coded the network maps using criteria previously used by Vasilev and shown here. These give us a sense of the types of network present in the data. Here are a couple of examples showing combined actual and imagined networks. P9 has a very small network, and P13 has a more diverse imagined network. We identified 2 central themes in our analysis. The first compared real and imagined social networks, and the second developed from our interrogation of the real network maps and the associated interview data, exploring what prompted this particular attendance. Those attending the ED for minor illness and injury tend to have small networks. Imagined networks were larger and more diverse. When asked, interviewees were able to suggest wider membership, including services that might assist, but these were often ruled out. There was a strong narrative of not wanting to bother people, as shown here. However, a second theme that we identified concerned how health professionals and wider healthcare systems influenced help seeking. One of the striking findings to emerge from our data was that, contrary to health education and policy rhetorics about appropriate attendance, patients often felt pushed by people outside their core familial and friendship networks to attend the ED. Some patients worked incredibly hard to avoid attending the ED. Patient 26 outlines her journey here, and I don't want to pass judgment about the appropriateness or not of her attendance, but simply to illustrate the attempts she made to avoid the emergency department. In many cases, patients knew that the ED was not where they should be, but they were advised to attend by healthcare professionals or NHS 111. We were also struck by the role that other people in peripheral social network locations played in encouraging ED attendance. Some of those who attended the ED described how workplace network members informed decision making. Patient 6 worked in a school, and filling in the accident book prompted them to attend the ED. Patient 11 was injured at home, but needed a fitness to work certificate to comply with health and safety in his work environment. Patient 9 was injured in a public library, and a worker there called a taxi to take her to the ED. Patient 13 fell while in a cafe and was seen by a paramedic who happened to be there and brought this elderly man to hospital. Our interviewees did not draw on their wider potential imagined networks. They were often swayed by professional influencers, health services staff, and other workplace members. These findings challenge the discourse surrounding inappropriate attendance. They suggest we need a broader view of networks and the social drivers of help seeking. Minor illness and injury is a source of particular confusion for patients. The ED is one of the few constants in a fragmented health service landscape. It is well understood, and people attend despite long waiting times. Our study suggests that faced with acute minor illness or injury, people's networks narrow. They do not and cannot mobilise their imagined networks because the resources or connections may not be there or are difficult to engage. Many of the people we interviewed who'd attended the ED for minor conditions understood the debate about appropriateness, but they were often pushed by professional influencers to attend. Referring back to Vasilev's mechanisms for mobilising support, we argue that a reliance on professional influencers overrides navigation and negotiation. It shuts down collective efficacy. It's little wonder that attempts to encourage self-care or to discourage ED attendance via health education messages fail. The fact that the nurse, the first aider or NHS 111 told me to come here denies agency and legitimates attendance. Given this, the policy focus on the rationale and behaviour of the individual or their close informal network has been overplayed. While signposting is useful, these drivers in health and work systems warrant more attention. To date, there's been little effort aimed at interventions in workplace settings to deal with minor ailments and injuries. Indeed, the management of minor ailments of workers has traditionally been seen as the purview of occupational health. Cuts to these services, as well as a risk-averse culture, may be a system driver that has not hitherto been recognised as affecting ED demand. In addition, the risk-averse practices of clinical and non-clinical staff seem to push people towards the ED. This is especially true of NHS 111, where triage by non-clinicians appears to have increased, not decreased, ED and formal care use. Rather than perpetuating victim blaming by labelling attendance as inappropriate, policy and decision makers should consider how different professionals could better influence help seeking. We may need to shift the risk perceptions and advice offered by professional influencers. Signposting might better be directed to workplace first aiders, reception staff and the like, than at individual patients. And by attending to the wider social network and social features of help seeking, we may be able to open up possibilities for reconstructing patterns of ED attendance. Thanks for watching, and thanks again to my fabulous co-authors.